welcome to my channel. Today's topic which we're going to study together is actually diuretics, and for the agenda of the day are the following topics. First, we're going to start with the introduction about the topic, then we're having a quick revision about the nephron, then we will understand what are actually diuretics, and in the end we have the following four groups which we have to learn today. The first one is carbonic anhydrase inhibitor, the second one is loop diuretics, the third one is saluretics or thiazides diuretics, and the last one is potassium sparing diuretics. And of course, in the end, we're going to end our study session today with a quick revision. Just a quick reminder, in the previous videos I have explained and given a small tip how we should study pharmacology. So, as we're going to see today, first of all, we're going to start with quick revision of the nephron from the physiological point of view. Then we're going to understand what is reabsorption and how the diuretics as medications are going to interfere with the reabsorption and what will be the final outcome. Afterwards, we're going to see all of the separate four groups and actually on which parts of the nephron they are acting on. So let me start. The first thing which we're going to revise today is actually what is a nephron, where is the nephron is located, what is the structure of the nephron, what is the function of a nephron, and how many types of nephron do we know. So those are the most important 5 questions which we have to understand before we're going to study today pharmacology. As I said, we're starting with the physiology, afterwards we're moving to the pathophysiology, and in the end we're understanding the pharmacological part of this topic. So, what is actually a nephron? Nephron is the smallest structural and functional unit of the kidney. So here we have one picture of the kidney. Quick reminder how many parts the kidney has. It has 2 parts. We have the cortex and the medulla. Then we have the next question. Where is actually the nephron located? So, in general, the nephron can be located in both of parts, either in the renal cortex or in the renal medulla. The third question is, what is the structure of a nephron? So, the structure of the nephron, as we can see here more clear on this picture, is the following. We're having the renal corpuscle, which is made out of the glomerulus itself and the Bowman's capsule. So this is the first part, and the second part of the nephron is actually the renal tubule. Now the renal tubule is all of those parts which are subdivided into a proximal convoluted tubule. Then we have a loop of Henle, which is divided into 2 parts. We have the descending limb of loop of Henle, then ascending thin limb of loop of Henle, and then we're having the thick ascending loop of Henle. Afterwards, we have the distal convoluted tubule, and in the end, we're having the collecting duct. Now, probably you're thinking, okay, but why do I have to know which type, which are the parts of the nephron? This is a question which we have to understand before we go to diuretics. Why? Because the diuretics as a medications are actually acting on the nephron itself. That's why it's very important for today's topic we to understand what is a nephron, that our kidney has the smallest unit which is called a nephron, and there are millions of nephrons which are found within the kidney. Second thing which we have to understand, that the kidney is made out of cortex and medulla, and we can find actually the nephrons in the cortex and in the medulla. Third thing which we have to understand and remember today is what is actually the structure of a nephron. As we said one more time, this is the renal corpuscle, which is made out of glomerulus and Bowman capsule, and the second part is the renal tubule. Now, another important question is, what is actually the function of the nephron? The function of the nephron is to filtrate the blood, to remove all of the waste of our body, and in the end, of course, to form the urine. And our last question, which we have already answered, is how many types of nephron do we know? So we know actually two types, cortical nephron and juxtamedullary nephron. Okay, so please in the comments write what is the difference between the juxtamedullary and the cortical nephron. This is like one small question which I hope the students who are going to watch this video would like to answer in the comments. Then another very important things which we have to remind ourselves is, what is reabsorption and how does it actually work? So, reabsorption is a process by which all the useful substances which are taken back from the glomerular filtrate into our bloodstream. Because we know that while the formation of the glomerular filtrate, not all the wastes which are going into the primary filtrate have to be taken away from our body, and not all of them are useless. So reabsorption is one process by which all the useful substances can be taken back from the glomerular filtrate into the bloodstream. How does it work? What does it mean, this question? This question means in which way the reabsorption is really happening. It is happening in the way that we will have special type of transporters and co-transporters which are found along the nephron tubule, and by the processes of a simple diffusion, um, active diffusion, or osmosis, or active transport, the molecules of interest, or the molecules which are still useful for us, are going to be taken back from the filtrate, which is found within the lumen of the tubule. They will be shifted through different type of transporters back into the cells. So now let we dive a little bit deeper into the different type of channels which we have in different part of the nephron. So on this slide you can see are written on this side all of the parts of the tubule itself. We have subdivided it into 4 as it is, and then we have different type of transports. It is very important for you to understand the transports, and now probably you're wondering why, because different type of medications are acting on different type of transports, and they're interfering with different type of transports. That's why, please, when you're going to learn the topic about the diuretics, we have to really clearly know which type of transport in the kidney is happening, in the nephron is happening in which part, and which medication is going to block which type of transport. Why is this important? Because different type of molecules are going to be excreted. So let we start. The first one is the proximal convoluted tubule. The proximal convoluted tubule is this portion here. The most important transports in the proximal convoluted tubule is the sodium transport. This is one type of active transport. As well, here is happening the secondary active transport of glucose and amino acids. What does it mean, secondary active transport? This means with the help of the primary, like sodium, we will have one type of co-transport. So while the transport of the sodium, we are as well going to use the energy and have co-transport of glucose and the amino acids. Afterwards, we're going to have reabsorption of water by osmosis, and as well reabsorption of a bicarbonate and a chloride. They will be reabsorbed with the help of the simple diffusion or active transport. Now we're going in the second part. The most important transport which we're going to have in the second portion of the loop of Henle is actually the sodium, potassium, and chloride transport which is found on the ascending limb of loop of Henle. Then we're moving to the third part. This is the distal convoluted tubule. Here we are having another type of transport, which is the sodium and chloride transport. Yeah, this is just a simple sodium chloride transport. Please remember this one because we will have a medications which are going to block exactly this transport and interfere with the reabsorption of the sodium chloride. And in the end, we are having the collecting duct, which is the last portion here. And in the collecting duct, we're going to have two type of transports. We will have one transport which is happening here, as you can see, potassium and hydrogen. And additionally, here we have sodium. But as we can see here, very important hormone is aldosterone. So what we have to remember about the collecting duct, that here we have active transport of sodium due to the help of aldosterone, and as well we have water reabsorption by help of osmosis, and as well the antidiuretic hormone. On the other hand, we have secretion of the potassium and hydrogen. So this is everything what we have to remember about the basic structure and the basic transport which is happening within the nephron. Okay, now we go to the question of today, diuretics. First of all, what are diuretics? This is a class of medications which will increase the urine formation, and by increasing the urine formation, they are going to decrease the blood pressure. Now, the very important question is how they can increase the urine formation. They can increase the urine formation by preventing the reabsorption which we just spoke about. Mainly they are blocking the sodium reabsorption, and as we know, sodium is always followed by water. This means if we block the reabsorption of sodium, we are as well blocking the reabsorption of the water, which means what? That sodium is going to stay within the tube, going to stay in the tubule, which means water is going to follow sodium, water is going to stay in the tubule as well, and this will lead to increased urine output. Once we have increased urine output, this means in general we will have decreased or reduced fluid overload. If we have decreased fluid overload, this is going to act in two ways. This is our next question. In two ways. The first is going to decrease the preload, and the second, or indirectly, is going to lower the afterload by decreasing the blood pressure, of course, and by decreasing the vascular resistance. And in some diuretics can also act by causing a vasodilation, which can furthermore decrease the peripheral resistance. Now, what is the classification which we have already mentioned, or which are the classes which we have to know of diuretics? As I have explained that the classification, we can also see this here, that the classification of diuretics is based on which part the medications themselves are acting on. So here we have four classes. The first one is carbonic anhydrase inhibitors, which are acting on the proximal convoluted tubule. Then we have the loop diuretics. They are acting on the ascending loop of Henle by blocking the sodium chloride and potassium cotransporter. Then we have the saluretics, which are acting on the distal convoluted tubule, and potassium sparing diuretics, which are acting on the late distal convoluted tubule as well as the collecting duct by two mechanisms. As we said, the first one is to block sodium directly, or second is to inhibit the aldosterone receptor. So when we're going to reach the potassium sparing diuretics in this lecture, please revise what was the function of the aldosterone. We have spoken about this in the previous video. and what is RAS system. Okay. Now here one more time, I have made one slide in which it's explained the classification and which are the most important transporters which are found in which part of the nephron. Okay, so we're going to start with the first one, which is the carbonic anhydrase inhibitors. This picture I have taken it from one Google file. I can upload the link from this file, and as well I'm going to upload this presentation. About the carbonic anhydrase inhibitors, we are going to ask ourselves. So this is the first medication which we're learning from 4. This means on which part this medication is going to act on. Immediately, we have to think the first part of the nephron was actually the proximal convoluted tubule. This means the carbonic anhydrase inhibitors are going to act on the very first portion of the nephron. Now, what we can see here from this picture is here we have the lumen of the tubule. Here we have the apical surface of the proximal convoluted tubule cells. And here we have the basolateral surface. This means the reabsorption in general, let me just be clear here, the reabsorption is happening by, in the tubule, in the lumen of the tubule, it's found the filtrate. And the molecules which are useful should shift from the filtrate itself, which is found in the lumen, into the cell. And from the cells, through different transports, they are going to be reabsorbed into the bloodstream. And in this way, our body can use them again. Now, here, one of the most important co-transporters, which is of our interest today, is the sodium hydrogen co-transporter, or as well we can call this antiport, because we have movement of molecules to molecules in a different path, opposite direction. That's why we can also classify it like antiport. So for this here transporter, we have 2 molecules. The first one is sodium and the second is hydrogen. And what is happening? Sodium is moving into the cell, hydrogen is moving out of the cell. Now, and in this way, actually sodium is getting reabsorbed back into the cell. What is actually happening with the hydrogen, which is going to be transported into the filtrate? The hydrogen is going to bind together with the bicarbonate, and together they are going to form the carbonic acid. Now, the carbonic acid is going to be divided into water and carbon dioxide with the help of the carbonic anhydrase. This is an enzyme. Then the carbonic anhydrase, then the water and the carbon dioxide by simple diffusion are going to enter inside in the cell. Then they will get rejoined with the help of the carbonic anhydrase again. And then the carbonic acid itself is going to be split into hydrogen and bicarbonate. And later on, the bicarbonate itself is going to get reabsorbed. Now, probably you're wondering why actually we have to know this entire mechanism. So this is one of the mechanisms which is happening in our body to balance the acid-base balance. And in case if our pH drops, this means our body will going to need to increase it in some ways. And how does it do it? By increased reabsorption of sodium bicarbonate. By reabsorption of bicarbonate itself. Now, what is the idea is that in this transport, our main molecule which participates is sodium. And we said that diuretics themselves are acting by what? Mainly blocking the sodium reabsorption Why? Because sodium is followed by water. This means if we decrease the sodium reabsorption, we're going to decrease the water reabsorption. And in this way, we're going to increase actually the urine formation. Once we have increased urine formation, this means we will reduce the fluid overload in the body, and in this way we want to decrease the blood pressure. So our main character which we have to remember here is the sodium. But when we're studying now about this medication, carbonic anhydrase inhibitor, this medication is not acting directly on sodium, but it is acting on the carbonic anhydrase, the enzyme which is going to split the carbonic acid into water and carbon dioxide. So by blocking the carbonic anhydrase enzyme, what is going to happen in the urine is going to stay the sodium and as well the bicarbonate. So we will have formation of a sodium bicarbonate and increased excretion of sodium. And once the sodium is excreted, water is going to follow sodium. And in this way, one more time, we will decrease the blood pressure. So the medications from the group of carbonic anhydrase inhibitors are acetazolamide, or you can learn all of the medications which are ending on zolamide. Acetazolamide, brinzolamide, dorzozolamide, like these are the three medications which I have chosen. Now, the mechanism of action, we have explained it very clearly. We have explained one more time which molecules of our interest, like sodium, where the medication exactly is blocking and what is happening, that once we have blocked this medication, sodium cannot enter the cell. Why? Because once we have blocked, this means hydrogen is not going to exit. This means this co-transporter here is not going to work. What does it mean? This means that sodium is going to stay in the urine, bind together with the bicarbonate and form sodium bicarbonate. While now we have to talk about side effects. Meanwhile, sodium is staying in the lumen, hydrogen is staying in the cell. Once, let we remind ourselves for one last time, if hydrogen stays in the cell and we have increased amount of hydrogen in the cell, what is going to happen? We're going to decrease the pH. This means if hydrogen stays into the cells, we're going to have our side effect of the medication, which is acidosis. Now, this is one of the side effects as well. We can have like hyponatremia and so on. On the other hand, this side effect can be useful in some cases. Let's say if our patient is it's hiking in very high mountains, you know that there the people who are hiking actually are very often exposed to hyperventilation because of the amount of oxygen which is found in the air. That's why, due to the hyperventilation, these people are going to have mountain sickness, alkalosis. So if we would give this medication which is causing acidosis and they themselves are having the mountain sickness, alkalosis, in some way we can balance it. Okay, and another use of these medications is when we want to use it for glaucoma. Then carbonic anhydrase inhibitors are given mainly with timolol together because in this way they can decrease the ocular pressure. Overall, this medication is not the most used medication when it comes to decreasing the blood pressure. We mainly use the next group, which is the loop diuretics, the furosemide, but these medications are also part of the group of diuretics, even though they are not mainly used. Now, our next group of medications are the loop diuretics. Our drug of interest today is the furosemide. Furosemide is acting, as we said, on the ascending limb of loop of Henle. And here we have one co-transporter of sodium, potassium, and chloride. What is happening? The loop diuretic is directly binding to this receptor, and it is going to inhibit this transporter. That's why what is going to happen? Sodium, potassium, and chloride are going to stay in the urine, and they are going to be excreted. Meanwhile, they're excreted. Here we have one typical paracellular transport. Paracellular, this means it's happening between the cells of calcium and magnesium. And because we're going to disturb or interfere on this co-transporter with the loop diuretics, this transporter of calcium and magnesium is also going to be disturbed. That's why we will also excrete the calcium and magnesium in the urine. So as you can see here, the side effects are going to be more. Why? Because more molecules were excreting. So we have hyponatremia, hypochloremia, hypokalemia. Then we have hypocalcemia and decreased amount of magnesium as well. On the other hand, one of the very important side effects is the hyperuricemia, because loop diuretics are going to compete for the same receptor. So loop diuretics are not really competing for the same receptor, but for the same transporter. That means that with competing with uric acid. This means that if loop diuretics are going to take the transporters of uric acid, what is going to happen with the uric acid in the body? It is going to rise. That's why we're going to have hyperuricemia. And the last side effect, very important, is ototoxicity. So if you remember, the endolymph in the cochlea has very high levels of potassium. And once we give loop diuretics to our patient, we're going to disturb the amount of potassium in the endolymph, which can lead to ototoxicity. That's why we should not combine diuretics, loop diuretics, with medication which have a similar side effects, like aminoglycosides, which are antibiotics. And now, overall, once we have blocked this co-transporter, sodium is staying into the urine, is going to be excreted. Once it's going to be excreted, water is going to follow sodium. This means we're going to decrease the fluid overload in our system, and in this way our less blood is going to reach the heart, and as well we're going to decrease the blood pressure and decrease the vascular resistance, and in this way we're going to decrease as well or lower the afterload, which makes it actually very much easier for heart to pump. Then we have the next group of medications, which are saluretics. The drugs here are divided into two groups. We have thiazides and thiazides-like. The thiazides are chlorothiazide, hydrochlorothiazides, while the thiazides-like are chlorothalidone, for example. First question, one more time, where do they act on? Which part? So they're acting on the distal convoluted tubule. Next question, which transporter they are blocking? They are blocking the sodium chloride co-transporter. This means again sodium is going to stay where? It is going to stay in the urine. It's going to be excreted. Water is going to follow sodium. And in this way we will again decrease the fluid overload. Now, here, which is one of the side effects which we can remember, is the calcium, that here we have one specific transporter of calcium, and that we can have slightly increased calcium reabsorption. The side effects of these medications are hyponatremia, hypochloremia. Again, these medications can cause hyperuricemia just in the same way like loop diuretics by competing for the same transporters, but they do not cause ototoxicity. and which is typical for these medications that they can lead to hyperglycemia. So, in which type of patients we should take care of when we would like to give saluretics? In case one of the side effects is hyperglycemia, please write in the comment. Again, when do we use this one? When we have to decrease the hypertension, when we're having edema, or in case of heart failure, just like all of the medications which we have studied until now. And the last group of medications is potassium sparing diuretics. Here we have two groups which we have to remember. Aldosterone antagonists. This means this is a group of medications which are directly blocking the aldosterone. And the second one is sodium channel blockers, the one which are directly blocking the sodium channel. Now, before we continue to the potassium sparing diuretics and say their names, the aldosterone antagonist is spironolactone, sodium channel blockers, one example, amiloride. What we have to revise from the previous video here is about aldosterone. What is the function of aldosterone? As we remember that aldosterone is a hormone which is released by the adrenal gland, and it is acting where? On the collecting tubule, into the distal convoluted tubule. And as well the collecting duct. Now, what is the main idea here? What was the function of aldosterone? The function was to increase the sodium reabsorption and to increase the potassium excretion. And one last question, how was actually the aldosterone, why was actually aldosterone released? What stimulated? What was the reason why the aldosterone itself was released? So aldosterone, one more time, is taking part of the RAS system. RAS system was activated when we have hypotension and when we wanted to regulate the blood pressure. So when we would have a low blood pressure, RAS system is going to be activated. Renin was released from the kidney. Renin was going to convert angiotensinogen into angiotensin 1. Then angiotensin 1 is going to be converted to angiotensin 2 by the angiotensin converting enzyme. And the angiotensin 2 is going to bind to the angiotensin receptor 2. And in this way, aldosterone is going to be released by the adrenal glands, and it's going to cause what? Sodium reabsorption. This means if we will reabsorb sodium, sodium is going to be followed by water, and we're going to increase the circulating volume. Now, when we talk about potassium sparing diuretics, the function is exactly opposite. We want to reduce the fluid overload or the circulating volume. How? By blocking the aldosterone. This means if we block the aldosterone, this means indirectly we will block the sodium reabsorption. First, or by blocking directly the sodium channels when I'm really sorry, where the sodium won't be reabsorbed. So in this way, we will decrease the sodium reabsorption, which means sodium is going to stay in the urine, sodium is going to be followed by water by osmosis, and in this way, what is going to happen is that we're going to have decreased overload. But on the other hand, what is the main idea? It's called potassium sparing. This means by some mechanism, the potassium is not going to be excreted, and potassium itself is still going to be it's going to be absorbed because of not it's not going to be absorbed, sorry, it is going to stay within the cells. The question is why? Because if we block aldosterone, this means we block sodium reabsorption and potassium excretion. That's why potassium is going to stay into the cells and it can cause hyperkalemia. So if we have already a patient who has hyperkalemia, potassium sparing diuretics are not our drugs of choice. And the potassium being in the cells is going to lead to acidosis. So the side effects is going to be acidosis, hyperkalemia, and hyperchloremia as well. So this is all what I have prepared for our today's lecture. I'm going to record one more video where we're going to go through the pharmacokinetics and pharmacodynamics, all of the drugs one by one. And please text or email me on this email so I can send you this presentation. Thank you so much for the attention, and we see each other soon.